Dear audience, dear chair, welcome. I would like to present my PhD thesis, which is about diabetes mellitus and its effect on oral health. My name is Bulcsú Bencze. I'm a second-year prosthodontic resident and a first-year PhD student in the Translational medicine program. My supervisor is Daniel Vég, my SMS is Bianca, and our statisticians are Bencze Szabó and Gergely Agócs. My vision is to provide adequate dental treatment to the systematically compromised patients, focusing particularly on prevention and prosthetic rehabilitation. In order to achieve this, I would like to find and provide scientific evidence in the possible correlations between diabetes mellitus and oral complications. Currently, we have two ongoing projects. Both of them are systematic reviews and meta-analyses. The first project, which we have started in 2022 September, is about investigating the effects of different HbA1c levels on the severity of dental implant complications. The background for this topic is that there are more than 400 million people suffering from diabetes mellitus worldwide, and this number will only increase with another 150 million by the end of this decade. Moreover, patients with diabetes mellitus tend to lose twice the amount of teeth compared to the systematically healthy individuals. And patients with chronic hyperglycemia have an increase in the formation of advanced glycated end products. These products can interact with their receptors, which are called RAGEs, and they release pro-inflammatory cytokines, the likes of interleukin-1 beta and TNF-alpha. All of these can be found in the periodontal tissue as well, and they can cause alveolar bone loss, both around dental implants and around natural teeth as well. We can measure a patient's last 2 to 3 months of average blood glucose levels with the help of HbA1c, which is actually advanced glycated end product of hemoglobin. Therefore, our aim is to find an adequate HbA1c level to provide safe dental implantation without long-term complications. To answer our clinical question, we have used the PFO format. Our population consists of patients undergoing dental implantation. The prognostic factor is either diabetes mellitus or prediabetes, and we have numerous clinical outcomes, but our primary outcome is crestal bone loss. We have done our systematic search on the 13th of November last year in the 3 main libraries with a simple search key which consists of 2 different domains. The first domain is for the population, while the second one is for the prognostic factor. We have gotten around 2,200 articles, and after the selection procedure, we were left with 35 eligible observational studies. About the results, I would like to show you the results on our main outcome, which is crestal bone loss. Crestal bone loss is one of the hardest outcomes to measure dental implant success. It is calculated from a standard periapical X-ray between 2 points. The first point is the uppermost part of the alveolar crest in contact with the dental implant itself, while the second point is the implant abutment junction. The literature says that there is a baseline alveolar bone loss around dental implants, which should not exceed 1 millimeter after the dental implant placement, and 0.2 millimeters for each subsequent year afterwards. For this analysis, we have used, for effect sizes, mean differences with 95% confidence intervals. The results are in millimeters, and we have 19 studies in this analysis. We have used subgroupings based on the patient's glycemic control. We have differentiated between poorly controlled and well-controlled patients, and we have placed patients with prediabetes in a separate group as well. The overall outcome for this result is 1 millimeter, which is both statistically significant and clinically relevant as well, since if we take into account the 0.2 millimeters of yearly bone loss around dental implants, this number is clinically very relevant. We cannot generalize this number, however, for the patients with diabetes mellitus, since, as we can see, it is highly affected by the quality of glycemic control. For example, patients with well-controlled glycemic status, they have a non-statistically significant difference, so they are comparable to patients without diabetes mellitus, while on the other hand, patients with poorly controlled glycemic status have a very significant 1.8 millimeter difference. We have also done meta-regression in this topic, comparing the association between crestal bone loss and HbA1c levels, and also follow-up duration and disease duration. We have found statistically significant associations between HbA1c levels and follow-up duration. For every single percentage of HbA1c increase, there is about 0.25 millimeters of crestal bone loss increase. And for the follow-up duration, it is around 1.2 millimeters. So we can say that both HbA1c and the duration of diabetes mellitus have a significant impact of the crestal bone loss around dental implants. The strength of our study is that we could include high number of up-to-date studies, while also we had a very strict exclusion criteria to reduce confounding. We have also made multi-level analysis and meta-regression as well. Unfortunately, we have limitations because despite our subgrouping, the heterogeneity of our analyses remained very high, while also in the literature there is no population matching for oral hygiene. So almost always we had a very significant difference between oral hygiene in patients with diabetes mellitus and the systematically healthy individuals. Our conclusion is that patients with higher than 8% HbA1c level have significantly worse clinical outcomes. They face a higher risk to develop periimplantitis or periimplant mucositis. Therefore, our implication for practice is that if we plan dental implantation for a patient with diabetes mellitus, HbA1c measurements should be necessary. And if the patient have an uncontrolled diabetes mellitus, then it is highly advised to have a consultation with his or her diabetologist. Also, for patients with diabetes mellitus, we suggest at least a biannual dental prophylaxis. We have implications for research. Mainly, we need more studies. We need more studies with much more rigid HbA1c measurements upon follow-up times. And also, we would like to see what happens when both the diabetes mellitus group and the systematically healthy individuals have the same oral hygiene indexes. And also investigate the effect of different HbA1c levels with other chronic factors such as smoking, obesity, and hyperlipidemia. Currently, we are at the language editing phase, and we would like to submit our article within the next week. Our main target journal is Diabetes Care, which is a D1 journal. Our second topic is about investigating the effect of diabetes mellitus on the survival rate of oral squamous cell carcinoma. For background, it is that head and neck cancers are very widely spread malignant diseases all across Europe, with Hungary being on the #1 place in terms of incidence rate per 100,000 capita, with 23 cases. This translates to roughly 3,000 new cases for every single year. Not only that, OSCC is very common, but it is the 11th most deadly cancer type in Europe. And in order to reduce its morbidity and mortality, prevention and early detection is key, and dentists can play a crucial role in this. There is evidence in the literature that patients with diabetes mellitus have a higher incidence rate in developing malignant diseases. This could be because mainly of hyperinsulinemia, which could promote malignant transformation through insulin-like growth factor receptors. Therefore, our aim is to investigate the association between diabetes mellitus and OSCC in order to help in the prevention and survival of the disease. We have once again used a pretty similar framework with population being patients diagnosed with OSCC. The prognostic factor is yet again diabetes mellitus, and our main clinical outcome would be disease-specific survival. We have redone the systematic search in the 10th of July with a similar search key in the 3 main databases. We have gotten many articles, a little bit above 14,000. Now the application removal phase is completed, and we are around 50% done with the title and abstract selection. As a recap, we would like to submit our first study within the next week and possibly finish with the second project in this year. I would like to thank your kind attention with a quote from Friedrich Nietzsche: "Truth tends to reveal its highest wisdom in the guise of simplicity." Thank you.
Thank you for the presentation. I would like to ask what's your current practice regarding implantation and diabetic patients today? Have you changed your practice, or have your colleagues changed your practice after your meta-analysis, or what's the...
Unfortunately, not yet. Thank you for your question. But our aim is to, if we have a successful publication, then we would like to change the practice, because HbA1c measurements is not really costly and it only takes a few minutes. And also at our department, we have dental implant consultations with the patients way before the dental implant placements. So it would be a perfect place to measure our patients' HbA1c levels. And if they have above 8% HbA1c level, we could consult with their diabetologist in order to reduce it below 8%. And I think it will be possible for our department to use this as an example. So we are planning to do this. Thank you.
About your first study, so yes, crestal bone loss, when you're saying mean difference of 1, that's a millimeter, right? 1 millimeter.
Yes.
Okay. With the crestal bone loss, as I understand, I'm not a dentist, so please correct me if I'm wrong, but it's not only the quantity of the bone loss, but also the timing is a cause of worry. Did you see from the analysis whether the uncontrolled glycosylated hemoglobin levels also associated with earlier crestal bone loss, or how much was the follow-up time?
Very good question. Thank you very much. Usually it does not affect that much in the early period. Within the first year, the difference between patients with diabetes or without diabetes, or the different quality control, it doesn't really affect the amount of bone loss. But if we are looking forward in time and we get studies with 3, 4, or 5 years of follow-up time, then the mean difference starts to be very significant. And for poorly controlled patients, it gets even harder. So I have to say that there is no evidence that the early bone loss is affected that much by diabetes mellitus, but the later time, it is very much affected by it.
Also because this morning, probably not very many people listen to Kossuth Radio, but I turned that on this morning, and actually Professor Merkeli was in a report that they found out a kind of modification of the classical pacemaker kind of implantation, and then he claimed that this will change actually the guidelines. And really, they published that in the best journal in the world, and then they really have a kind of strong effect on that, and then they are really appreciated high. And I happened to saw this paper actually, but they wrote, and then they also, actually stated that there is no guideline, and there should be some guideline statements on this. So this is not that easy, but I think this is an important study, because this will really, set the basis for some kind of guidelines which do not exist actually. So congratulations. This is what I don't know if you have any comments on this. Probably not on Professor Merkeli's stuff, but on your own. Thank you.